Good afternoon, good evening, or good morning, depending on from when or where you are joining us. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to CDC Public Health Grand Rounds for October 2018. I especially would like to welcome what I call lifelong learners that attend almost every session. Thank you very much. We have an exciting session today. Let's get started. But first, a few housekeeping slides. Public Health Grand Rounds has continuing education available for physicians, nurses, pharmacists, veterinarians, health educators, and others. The course code is PHGR10. Please see our website or theirs for more details. This is the disclosure slide for this session. Grand Rounds is available on all your favorite web and social media sites. Please send questions to grandrounds@cdc.gov, and we will try to include them in today's Q&A session. Want to know more? We have a featured video segment called Beyond the Data, which is posted after the session. This month's segments feature my interviews with Dr. Henke and Dr. Goodstein. We have also partnered with the CDC Public Health Library to feature scientific articles about this session. Please see the full listing at cdc.gov/scienceclips. Here is a preview of the upcoming Public Health Grand Rounds topics. Please join us live or on the web at your convenience. In addition to our outstanding speakers, Dr. Parks Brown, Mitchell, Colson, and Henke, I'd also like to take a moment to thank the individuals who contributed to the session. Thank you. And now for a few words from CDC's Deputy Director, Dr. Ann Schuckett.
Well, thanks so much, Phoebe, and welcome everyone to today's Public Health Grand Rounds on the topic of safe sleep for infants. Today's topic cuts close to home for far too many families around the country, and we'll be hearing from a variety of perspectives on the latest understanding of the issues and the critical needs going forward. A lot has happened in this field since I was in medical school. I attended medical school in the 1980s. Like most of my classmates, I'd gone straight to med school right out of college, but our class had a handful of people who had a bit more life under their belt. Some were even married, and a few already had children, and a few others had babies while we were students together. Our class was quite small, so these new infants were almost class mascots. So it was sudden, unexpected, and terribly memorable when the precious infant of one of my classmates died in his sleep. The loss we felt as friends and classmates was difficult. The loss for the baby's parents and extended family was truly unimaginable. If this could happen to a promising medical student's family, educated and with considerable access to the very best medical care, what did this mean for average families? I was truly heartened in the 1990s when I learned about the Back to Sleep campaigns. I even saw posters of those campaigns in front of the CDC's Clifton Road campus at the bus stop. There was something that we could do about this problem. Today, you're going to hear about the tremendous progress that we've had since the 1980s and the problems that we still have with ensuring that evidence-based solutions reach everyone who needs them. I hope you'll take this to heart and help make sure that we can accelerate the progress going forward. Today's speakers will make this personal. I hope that they'll also make it actionable for you. Thank you.
Thank you, Ann. And now for our first speaker, Dr. Parks Brown.
Good afternoon. There are approximately 3,500 sleep-related infant deaths in the United States each year. These deaths, also known as sudden unexpected infant deaths, or SUID, are deaths of babies less than 1 year old, which happen during sleep or in the baby's sleep area. This includes infant deaths from sudden infant death syndrome, or SIDS, and other undetermined causes, and accidental suffocation and strangulation in bed. Recent U.S. data has shown that the peak age of these tragedies is between 1 and 2 months. This graph shows the rates for all sleep-related infant deaths from 1990 to 2016. You can see that in the early 1990s, there was a steep decline in the rate of sleep-related infant deaths in the US. The decreases accelerated around 1992, following the American Academy of Pediatrics' initial recommendation to place infants on their backs to sleep, and the launch of the National Institutes of Health Back to Sleep campaign in 1994. By the late 1990s, however, the decreases in rates had slowed, and the rates have remained relatively unchanged since around the year 2000. These data support the importance of placing infants on their backs to sleep. Here, you can see as the percent of mothers who reported placing their babies to sleep on their backs increased, the number of deaths decreased. And as that percent leveled off, unfortunately, so did the rate of deaths. This is an area where increased awareness and social media campaigns, which you'll hear about more from Dr. Colson, could have an impact. From this map of the US, you can see that the rates of sleep-related infant death among the states varies widely. Based upon data from 2013 to 2015, the state-specific rates ranged from 33 in Vermont to over 200 per 100,000 live births in Alaska. There are stark differences in these deaths based on race ethnicity as well. American Indian, Alaska Natives, and non-Hispanic Blacks have the highest rates of sleep-related infant deaths, with rates for both being more than twice as high as those for non-Hispanic whites in the US overall. We also consistently see the lowest rates among Hispanics and Asian Pacific Islanders. Even after adjusting for other factors, race remains a significant predictor of sleep-related infant deaths. Much of the research on risk factors has been focused on deaths due to SIDS, but from what we know, the risk factors for all sleep-related infant deaths are similar. Things we know increase the risk for sleep-related infant deaths are non-supine, so stomach or side sleep position, sharing a sleep surface with another person, use of a non-firm sleep surface, such as an adult bed, use of soft bedding in the infant's sleep area, so that's things like bumpers, comforters, pillows, blankets, or even stuffed animals, as well as letting an infant get too hot while sleeping due to either high room temperature or excessive clothing. Prenatal use of alcohol or tobacco, and exposure to environmental tobacco, or being in the care of an adult under the influence of alcohol are also known to increase the risk. This means to reduce the risk for every sleep at night and at nap time, infants should be placed on their backs, on a separate sleep surface, preferably in the same room as their caregiver. The infant's sleep surface should be firm, flat, and level, so a surface like a crib, portable crib, or bassinet with a tight-fitted sheet. It should be free of thick blankets or pillows, bumper pads, or other soft objects. And the baby should be kept cool while sleeping, dressed in no more than one layer more than an adult would comfortably wear in that environment. It's also recommended that women stop smoking during and after pregnancy, and that parents not allow anyone to smoke around their infants. Women should also avoid alcohol use during pregnancy, and anyone responsible for infant care should not be under the influence of alcohol. So how common are some of these risk behaviors? Estimates are that more than 75% of all infants are placed to sleep on unsafe sleep surfaces. More than 60% at least occasionally share a sleep surface with at least one other person, sometimes multiple people, and almost 40% are sleeping with soft objects in their sleep environment. Smaller but still significant numbers are being placed on their sides or tummies to sleep and being exposed to tobacco or alcohol while in the womb. In addition to risk factors, we know that there are some protective factors, including breastfeeding and pacifier use. It's estimated that 60% of new moms are breastfeeding at least through their infant's first 2 months, and one population-based study showed that 32% of infants were put down for sleep with a pacifier. The prevalence of these risk and protective factors may help explain why these deaths continue to occur, and also explain some of the variation in rates that I mentioned previously. To help increase our understanding of the true burden and factors associated with sleep-related infant deaths, CDC supports the Sudden Unexpected Infant Death Case Registry. a multi-jurisdictional, population-based surveillance system. In addition to compiling detailed data on each death, each case is adjudicated and assigned a category using the CDC SUID classification algorithm. The algorithm was designed to provide a standardized grouping method that would allow for consistent monitoring of SUID over time, account for unknown and complete investigation information, which can inform improvements to case investigations, acknowledge uncertainty about how suffocation may or may not have contributed to deaths, and also allow for calculation of population-based incident for each type of SUID based on standardized groupings, thus allowing for consistent comparisons of different types of sleep-related infant deaths over time and across jurisdictions. Understanding the differences in rates of various types of sleep-related infant deaths is complex. Underlying the overall rate, there are some important changes taking place. Included here are the 3 subtypes of sleep-related infant death. You can see that in 1990, the majority of these deaths were classified as sudden infant death syndrome, or SIDS, shown in gold. That number decreased sharply with the national uptake of supine sleep in the early 90s and continued to fall, albeit more slowly after 2000. As you can see, the gradual fall in SIDS did not result in a corresponding decrease in the overall sleep-related infant death rate, shown in the blue line, but rather deaths classified as undetermined cause, shown in green, or accidental suffocation, shown in purple, increased. So the decreases in SIDS were being offset almost completely by equal increases in the other 2 types. So why might this happen? We'll hear from my colleague, Dr. Mitchell, a bit more about the work of medical examiners and coroners, but briefly, medical examiners and coroners are responsible for the investigation into sleep-related infant deaths, and they make the determination as to the cause of death. How they certify the causes and manner of death determines how the deaths will be coded in our national vital statistics systems. Those data are used to better understand the risks and potential prevention strategies. Traditionally, the 3 causes of death, as shown on the previous slide, are used to quantify sleep-related infant deaths. However, evidence shows a shift within the medical examiner and coroner community, resulting in fewer deaths being certified as SIDS and more as either undetermined or accidental suffocation. The reasons for this diagnostic shifting are complex and multifactorial, but include more thorough investigations into the circumstances surrounding each death, which has led to increased recognition of potential factors for suffocation, increased influence of multidisciplinary state and local child fatality reviews, and death certifier preference to not use SIDS. This shift impacts our ability to conduct surveillance and research over time and has significant implications for public health, and inhibits both our understanding of the true causes of these deaths and our ability to more effectively prevent them. In addition to the SUID case registry, several additional efforts are underway at CDC. As of 2016, 4 questions related to infants' safe sleep will now be asked of all respondents of the Pregnancy Risk Assessment Monitoring System. This will allow us to better estimate national prevalence of infant safe sleep factors, to identify populations at risk for unsafe sleep practices, and help improve safe sleep. We promote the American Academy of Pediatrics Safe Sleep recommendations, as well as NIH's Safe to Sleep campaign. And we also encourage adherence to these recommendations by our 22 SUID case registry awardees. We also indirectly support a number of hospital-based quality improvement efforts related to infant safe sleep through our perinatal quality collaboratives and the national network of PQCs. With that, I would like to turn it over to my colleague, Dr. Mitchell.
Good afternoon. I'm Dr. Roger Mitchell. I'm the Chief Medical Examiner for the District of Columbia. I'm honored to be here to share some thoughts about death investigations and safe sleep from the medical examiner's perspective. This is the Consolidated Forensic Laboratory in the District of Columbia, where the Office of the Chief Medical Examiner lives, along with all the forensic operations for the District of Columbia. There's a mixed medical legal death investigation system within the United States. About 50% is a coroner system, and about 50% is a medical examiner system. Everything that has a blue color is a full medical examiner system, and all the other states and jurisdictions have either a coroner or a mixed system. There's difference between a medical examiner system and a coroner system. A coroner is often an elected official, but may sometimes be appointed. The coroner is often not a physician and most often not a forensic pathologist. The medical examiner is usually an appointed physician and most often a forensic pathologist. This becomes important because the lack of uniformity in the nationwide medical legal death investigation system often translates to lack of uniformity in our child-infant death investigations occurring in the United States. I'll be discussing what we do in the District of Columbia, and this may represent either more or less than other offices. In the District of Columbia, infant death investigations are guided with the use of the CDC recommended SUIDI forms. This is a comprehensive tool used to gather investigative information to determine the final cause and manner of death designation. There's particular information that's collected during the sudden unexplained infant death investigation. For background, the majority of infant deaths in the District of Columbia are transported to and from the hospital. Therefore, the initial reporting entity is usually an area hospital, a nurse, a fellow, a resident, or even an attending physician. Our investigators are going to obtain following key information like name and age and race and gender, the name of the physician, whether or not a clinical exam was done. We're going to respond to the home after that information is gathered from the hospital. And while we're in the home, we're going to ask for household relationships, who found the decedent, identifying the caregiver, recent changes in behavior or illnesses, particularly within the last 72 hours. And then where was the child placed and where was the child found, and what were the circumstances of that? Were they found on their back, side, front, including their neck and face position? While we're asking questions of the caregiver, we're going to attempt to perform a doll scene reenactment. Investigators during that time will work with family to communicate the purpose and acknowledge the difficulty of going through this process. We reaffirm that the process that the OCME is just to understand all circumstances. We're going to allow the caretaker to place this doll in a placed location and also then in a found location. We're going to take a set of photographs and document the scene as we would any normal scene death investigation. This is the doll that is used. It is gender and race neutral in order to minimize the emotional response. The doll is filled with a sand-like material and has very similar weight as a true infant. Some offices dress the doll in order to know the back from the front. Others mark the doll front and back. Well, once the preliminary investigation is performed, all sudden unexpected or unexplained infant deaths cases undergo a full autopsy examination. We're going to do first rounds as is photography. We're going to measure the length, weight, head circumference, crown, rump length. We're going to take second rounds of photography. We're going to perform a layered torso dissection looking for abuse or neglect. We're going to explore the entire body cavity and perform dissections, doing weight and histology. We're also going to complete a full head dissection. Neuropathology is also often done, and optic nerve dissection is done. Sometimes we have to remove the eyes of the globe of the eyes in order to look for retinal hemorrhages. And then we do a full skeletal assessment. That skeletal assessment that we do is one that requires an anthropology consultation. And that anthropology consultation will be looking for trauma. So how do we certify these deaths? Well, in the bed sharing or co-sleeping cases, we're looking for evidence of asphyxia. That would be anterior lividity or petechial hemorrhages of the eyes, mouth, and thymus. Or we're asking for a history of rollover as given by the bed sharing adult. If this type of information is available or observed, then the cause and manner of death are usually certified as cause of death asphyxia, manner of death accident. If this information is not available, then often the cause of death is established as undetermined bed sharing, manner of death undetermined. These are a subset of the cases that may have been called SIDS in the past. If we're certifying a death that is of unsafe sleep, we're going to be asking questions of whether or not the infant was placed face down or in soft bedding, or was the sleeping occurring on couches, car seats, or recliners. Often these cases have no physical findings and no gross evidence of asphyxia. But because asphyxia is a possible cause, the cause of death are often called undetermined, manner of death undetermined. This is also a category that previously may have been called SIDS. So I'm the co-chair of the Child and Infant Mortality Review Team for the District of Columbia. These teams are important to understanding the risk factors, as you heard before, and circumstances that may lead to death. It's a multidisciplinary team that looks at the socioeconomic determinants of health and family dynamics, the health of the mother and the family and caregivers, birth history and health of the infant, sleeping arrangements, circumstances surrounding death. It is charged to develop systemic recommendations for improvement in the city to decrease mortality. We set policy. This year, we'll be incorporating a maternal interview so that we can gain a better understanding into the barriers of prenatal care and barriers to safe sleep practices. So lastly, I'll end with a case example. This is a 2-month-old, 4-day infant male found unresponsive by the father, bed sharing in a supine position. The father describes the placing the baby down and then dozing off. The father woke up and found the baby unresponsive in the same position. There's no recent illness, 50 percentile in weight and height for age, developmentally normal, no external or internal evidence of injury, and no anatomic cause of death identified. As I described, we would go to the hospital and talk to the clinician and ask what he found or she found at examination. Then we would go to the home looking for the living conditions and to perform a doll reenactment. There's evidence of smoking and marijuana use in this home. Not all sudden and unexpected infant deaths have smoking or drug use, but it is important to point out when this does exist. There is evidence of smoking and marijuana use, as you can see. We always look for evidence of nutrition and groceries in the home. And then we perform the doll reenactment. This is how the infant was placed. You can see that is an unsafe sleep environment with soft bedding and bed sharing with an adult. This is how he was placed, and then this is how the father found the child in the same position. The cause of death was established as undetermined and bed sharing because of the unsafe sleep environment and the possibility of asphyxia. Other conditions listed was sudden unexpected infant deaths, and the manner of death was listed as undetermined. Sudden unexplained infant death investigation is not easy, and as we learn more, we will have a greater opportunity to improve the diagnosis. Medical examiners and coroners must continue to attempt to unify our practice so to ensure reliability and reproducibility in the cause of death and manner of death designation of this vulnerable population. And now for our next presenter, Dr. Eve Colson.
Thank you, Dr. Mitchell. Good afternoon, everyone. I've spent many years thinking about behavior change and infant sleep, and I'm very glad to have the opportunity to speak with you today about this. The well-researched recommendations from the American Academy of Pediatrics aimed at reducing the risk of sleep-related deaths in infants include always back sleeping, no things in the infant sleep space, for example, no soft blankets, no pillows, no stuffed animals, and no bumpers. In addition, infants should room share, but not bed share. This slide shows the success that we've had with increasing back sleeping. As you can see that since the Back to Sleep campaign began in 1992, back sleeping has increased dramatically. Usual back sleeping went from about 16% in 1993 to 72% in 2007. Yet, even with this success, there are opportunities for additional prevention by further increasing back sleeping. Looking at the same slide, now with the data from African American mothers shown in yellow, you can see that in recent years, since 2001, there's been no change in back sleeping, and there's racial disparity. African American infants are less likely than others to be placed on the back to sleep. And there are also opportunities for prevention of bed sharing. As you can see, usual bed sharing increased from 1993 to 2010. Again, you can see the differences with race and ethnicity. You can see that the increase in more recent years is much more apparent in Hispanic infants, shown with the dark squares, and African American infants, shown here with the triangles, compared with white infants. Now I'm going to switch to talking about how to change behaviors. There are a number of approaches to understanding behaviors. One is known as the theory of planned behavior, which we've used for trying to understand behaviors related to safe sleep to develop effective interventions. Here the model shows that attitude, subjective norms, and perceived control can impact intention, which in turn predicts behavior. Regarding attitudes, for example, we have found that infant caregivers can be concerned that infants should not sleep on their backs because they might choke. Those who thought that infants can choke on the back were much less likely to choose that position. Subjective norms are also important. This is what the parents' advisors think about safe sleep recommendations. We learned that getting consistent information from all sources of advice was important. With bed sharing, for example, hearing from a pediatrician that the infant should share a room, but not a bed, made that more likely to happen. And finally, a sense of control can be impacted by, for example, the need to leave your child in childcare. They may not be able to control what the childcare provider chooses to do. Examples are when the grandmother serves as the childcare provider. To see if we could make changes to behavior, we recently conducted a randomized trial using what we have learned about health behaviors related to infant sleep. For this study, we had 4 groups of hospitals, each exposed to a different set of interventions, which you can see here. They received either a safe sleep intervention or a breastfeeding control in the nursery during the postpartum period right after birth. And then when they went home, they received either safe sleep or breastfeeding control mobile health text messages on their phones. To develop the intervention, we used what we had learned about behavior through our previous studies, and we conducted, in addition, focus groups and interviews with both hospital staff and parents of young infants. We then crafted messages. We used social marketing principles and worked with a marketing firm and a video production company. We developed a logo and a brand, which culminated with videos that taught safe sleep practices based on known barriers using our brand, which we call Today's Baby. For the postpartum hospital intervention during the newborn hospitals today, we developed laminated cards and slides, which aided nurses in teaching mothers, and PowerPoint slides for staff, which they could use for presentations or email blasts. We made available posters for staff to be hung in common areas and break rooms, and we also provided them with sample protocols to be used to create or modify their own hospital protocols. And they also received announcement letters, which were templates for campaign announcement letters for hospital staff and administration. All of our materials were based on information we learned from staff and from families about facilitators and barriers to following safe sleep recommendations. So, for example, we provided laminated cards, which staff could use at the bedside. This one specifically addressed concerns about choking. Showing a baby on the back, the nurse could read to the family, here, the trachea or airway is above the esophagus or food pipe. Anything that the baby spits up will be pushed back down to gravity to the lowest point, and the airway gets protected. On the other hand, showing the baby on the stomach, they could read, on the stomach, the trachea or airway is below the esophagus or food pipe. Anything that is spit up will be pushed back down by gravity to the lowest point. On the stomach, it's easier to aspirate into the lungs. Another of the laminated cards showed a mnemonic as a memory prompt to guide teaching for nursing staff. The mnemonic was SMILE. Share the testimonials, which we had from real patients printed on the cards. Model safe sleep behaviors at all times. Include all family and friends. This addresses social influences. Learn about beliefs and engage the family in discussions about their beliefs. Hospitals then used the materials we provided in the Quality Improvement Framework, an approach called Plan, Do, Study, Act, or the PDSA cycle. They applied different approaches in rapid sequence and looked at the outcomes to see if they were improving. With this, we saw great improvement in following safe sleep recommendations. For example, we found that with this approach, the hospitals in the safe sleep intervention moved from about 50% recommending to families that they should keep soft bedding outside the sleep area to 90% making that recommendation. For the mobile health text intervention, we developed videos that are listed here that specifically addressed safe infant sleep recommendations with explanations that directly addressed what we learned to be facilitators and barriers to following recommendations. For example, we discussed choking and sleep position using the same pictures provided to the nursing staff that I showed you in the previous slide. These were delivered to the mother's cell phone via text messaging. Mothers had some limited opportunities to respond and then to receive feedback about their sleep position choices. What the intervention showed us was that the mobile health was very effective in improving adherence to back to sleep, going from about 80% in those who were in the control group to 93% for those who did not receive it. Room sharing without bed sharing increased from 70% to 86%, and no soft bedding went from 68% to 82%. Pacifier use went from 60% to 76%. These were all really impressive and significant changes. One important point to note was that the mobile health intervention really was the thing that determined much of the change, except with back sleeping, where the intervention in the nursery interacted with the mobile health intervention to improve the outcome in combination. And one thing to keep in mind as a limitation was that the findings were all the results of self-report from the mothers. So to summarize, we conducted a nursing quality improvement intervention that improved maternal report of education and observed infant sleeping practices in the hospital during the postpartum period, but did not on its own improve adherence to all infant sleep practices. Among the mothers of healthy term infants, the mobile health intervention improved adherence to infant sleep practices compared with the control interventions. And these interventions, if implemented more widely, may improve adherence to safe sleep practices and therefore have the potential to reduce infant mortality rates. So what are our next steps? Next, we hope to have the opportunity to conduct another randomized control trial, this time with a prenatal component. That way, we would have a chance to see a broader impact starting safe sleep and a breastfeeding intervention during early education. We would be targeting specific populations to reduce disparities, specifically low income and minorities, this time including Spanish speakers with tailored messaging and appropriate images. We also want to explore the concept of falling asleep while feeding, which is a common occurrence, and we'd like to introduce the idea of planning for a sleepy feeding space and what that might look like. So I'll stop here. I thank you for your attention, and now I would like to introduce our next speaker, Dr. Henke.
Thank you, Dr. Colson. My name is Sam Henke. I'm a pediatric cardiologist at Cincinnati Children's Hospital, and I'm president of Charlie's Kids Foundation. I'm here today as the proud father of Charlie. This is a chart that has become familiar to many working to eliminate sleep-related deaths in the United States. It is a telling graphic that highlights the aforementioned diagnostic shifts and the plateauing of SUID deaths over the past 20 years. While this chart has been effective in communicating the high rate and number of infant deaths to those in this room, it has not been effective in changing infant sleep practices. What can be lost in these national statistics is the personal impact and realities of this impact on families across the country. I'm a father, here today representing one of those families. My wife Maura and I have been living this reality over the last 8.5 years. We are not alone in this loss, and I thank the CDC for the opportunity to be here today to give a small voice to the thousands of families who, like me, mourn the loss of our children and live this reality. This is Charlie. Charlie was born on April 6, 2010, and he was a healthy 7-pound, 11-ounce full-term baby boy. He was our firstborn son, and my wife and I were amazed at the first sight of him. He was perfect. We celebrated when we were able to bring him home. We read books, went on walks, and settled into a beautiful life as first-time parents. 3 short weeks later, I offered to help my breastfeeding wife to get a few needed hours of sleep during a particular fussy evening for Charlie. Charlie ultimately settled, and so did I. I sat down on the couch to watch TV and inadvertently fell off to sleep. I woke up. Charlie never did. There are no words to describe the impact of losing a child on families. Life changes forever. My wife and I were forced to move forward with a huge gaping hole in our hearts. But we knew there had to be more to Charlie's story than the 3 short weeks he was with us on this earth. My wife and I also knew we needed to do everything we could to help prevent other families from experiencing the same terrible loss. We were astounded by the fact that over 3,000 babies died each and every year from similar circumstances in the United States alone. As a result, we established a nonprofit foundation called Charlie's Kids with a purpose to eliminate sleep-related deaths, specifically by raising awareness of sudden and unexpected infant death, by educating families about SIDS, sudden and unexpected infant death, and safe sleep practices. We chose to use a children's book as the vehicle in which to spread this safe sleep messaging. We worked with a pediatrician and author, Dr. John Hutton, and illustrator Leah Bush, to develop our very own children's book, Sleep Baby, Safe and Snug, which is available in English and in Spanish. A children's book was chosen as it provides timely and repetitive messaging in the AAP Safe Sleep recommendations. It is an approachable and easy-to-read book. It targets all levels of education, language, and literacy abilities, and furthermore promotes important parent-child bonding. We primarily distribute these books in bulk through hospitals, health departments, and other nonprofits. And since 2013, we've distributed over 2.5 million books across the United States. And more importantly, we've seen a positive impact from caregivers using these books. Specifically, when used as part of a home visiting program, this book increases observed safe sleep behaviors and parent and baby bonding. When used in delivery hospitals, it improves safe sleep compliance by both families and healthcare staff. And finally, and most importantly, this book has been associated with fewer sleep-related deaths when distributed through statewide safe sleep campaigns. I'm fortunate to be here to share just one example of parents turning our pain into purpose, and it is my firm belief that all safe sleep campaigns should closely partner with local families who have been impacted by this tragedy. In my countless interactions with families and healthcare providers over the past 8 years, it has become clear that the unfortunate reality is there no consistent understanding of the brand of SIDS and SUID. Depending on the organization and audience, we call it different things: SIDS, SUID, cot deaths, accidental suffocation, strangulation in bed, and sleep-related deaths, to name a few. And the link between the desired behavior and the outcome is just not clear. Parents who live this tragedy can provide our stories that, when combined with statistics, can establish that vital link between sleep behavior and these sudden unexpected infant deaths. I think it's only after this link is well established that parents will choose safe sleep each and every time they put their baby to sleep. I would again like to thank the CDC for the opportunity to speak here today. I'm truly humbled by the opportunity to represent the thousands of SUID families across our country who have made an impact in countless different ways. And it's truly my hope that we can continue to partner together as we work to turn our pain into purpose and eliminate sleep-related deaths. With that, thank you guys, and I'd like to open this up for questions.
So first, I'd just like to thank Drs. Mitchell, Coulson, and Hankey for those wonderful presentations. With that, we are open for questions, and I think we'll start with Susan. Do you have any from the online audience?
Yes, we do. And I want to encourage our viewers to send their questions to grandrounds@cdc.gov, and we'll pose as many as we have time for within the session. We have a few questions. One is, are you aware of safe bed sharing campaigns that are promoted mother to mother and in parenting support groups? And do you have any plans to combat that messaging that bed sharing is safe when, and this person's included about 4 websites where that conversation is taking place?
Thank you. That's a very common question about how to make bed sharing safe. The American Academy of Pediatrics feels that at this time, room sharing without bed sharing is for sure the safest thing to do. We are certainly working with groups and thinking about messaging for the safest environment and helping people make decisions that make the most sense for them.
And we have more from our online audiences. Does CDC track the location of these babies during the time of death? It would be interesting to see the rate of co-sleeping deaths as compared to traditional crib sleeping techniques.
So I mentioned the SUID case registry in my portion of the talk, and we have very rich data on all of the cases that we include in the registry, including the sleep location, position, place, position found, usual sleep location, position found. So we do have those data, and that aspect that was mentioned in the question is something that we hope to be examining and publishing on very soon.
And I'll comment on that question as well. You can work with your local jurisdictions. Most medical examiners and coroners are using the SUIDI form. That SUIDI form is a series of questions that asks that. What are the sleep positions? And all of that should be gathered during an adequate sudden unexplained infant death investigation and should be categorized at the local level as well. CDC pulls from local data for the national data. So if that question asker is wants local information, they should work with their local medical examiner and coroner.
So I have a two-part data question and then behavior. So maybe for Dr. Parks-Brown or Dr. Mitchell and then Dr. Coulson. So the data part is there a risk factor of birth order in these deaths? And the behavior question is it a more difficult challenge to get the messaging through to parents if it's a second or third child versus a first child?
Well, I can speak to the first question first. Is birth order a risk factor? I am not aware of research in the literature trying to look at the association between birth order and SUID or sleep-related infant death, but it's always something someone might be interested in looking at.
From my experience as the co-chair of the Child and Infant Fatality Review in the District of Columbia, much of the babies we see are not specific to birth order. those babies that are dying in bed sharing environments. They may be the third or fourth baby. It tends not to be something that I see on a regular basis.
So the question about behavior is a great one. Certainly when people have had experience, they often like to stick with what worked for them from the beginning. So if they had their baby on the side or the stomach, they may not want to switch over with the next baby. And I think that was particularly challenging as the recommendation shifted a little bit. First it was side or back, and then it became back only. So in many of our focus groups and in-depth interviews, people said, so what is it? This is confusing. I think now, as we're going further out from the strict recommendation about back sleeping, people are learning more and more about that and accepting that more and more. I do think that bed sharing still has a lot of room to move with regard to that and people's decisions about whether or not to bed share. And in addition, people sometimes feel that sleep is a decision, a personal family decision, and not really a decision that they should be mandated by healthcare providers. So.
Just a quick comment on that as well. In engaging with families who have experienced loss, especially ones that were not first in birth order, a consistent conversation that we have is, I did this with my other babies and I thought it was fine. I think it's a difficult link between getting away with it, if you want to think of it like that, versus being unfortunate and having one of these sleep-related deaths.
Let's take another online and then we'll come back to the room.
From Vanessa, when is it time to sleep prone? When is it safe to sleep prone? Once the child can get prone independently, or when they can roll in both directions, supine to prone and prone to supine?
Okay, so when is it okay for the baby to sleep prone? What we usually say is the infant should always be placed on their back to sleep when they're placed to sleep, knowing that developmentally, at various stages, infants will learn how to roll over onto their side and to their stomach. And that's why it's also very important to always keep everything out of the crib, that the child should sleep in a safe sleep space, safe sleep service, because you never know when that rolling is going to occur. We also say that we don't want families to be super nervous and hover. They're nervous enough about baby sleeping, so they don't have to watch to when the rolling may happen. And when it happens, it's fine to leave the baby rolled over. They don't have to stand all night waiting for that roll to happen, but just making sure that everything stays away, which also brings up the idea of swaddling. The AAP recommends that swaddling is okay until the baby seems like they're going to either roll over or they reach 3 months of age, because you don't want a baby rolling over while they're swaddled. They'll have a lot of difficulty keeping their airway safe.
Are there more questions? Yes.
I guess my question is for Dr. Mitchell. I'm curious, do medical examiners and coroners use standard protocols for how they conduct these investigations to certify deaths? So you shared a slide about an autopsy protocol. Would that be the same protocol that you use in DC? Would that be the same protocol that would be used in another part of the country?
So that's a really good question. And there are recommendations for uniformity. The National Association of Medical Examiners has set forth autopsy recommendations as it relates to both adults and infants. Also, the National Association of Medical Examiners has adopted the sudden unexplained infant death investigation recommended by the CDC as the investigative tool for gathering information surrounding it. But to answer your question directly, across the entire country, there is not a uniform of practice. So there may be a different practice in a coroner system or another medical examiner system than my particular medical examiner system.
Susan, more from the online audience?
Yes, thank you. We have several coming in here. Are you able to tease out information about feeding method? Is there statistically significant difference in death rates between exclusively breastfed infants versus mixed fed versus exclusive formula feeding?
Okay, what I can say is there for sure is an advantage to breastfeeding. And I'll just be honest that I do not remember the data about the different subtleties about how much breastfeeding is necessary. But what I would say is breastfeeding definitely decreases the risk.
Yes.
So I just wanted to thank Dr. Hanke for coming over and sharing the story and for establishing the foundation. I had a two-part question. One is that the risk factors you've described, do you weight them? Is one risk factor more weighs higher than others as you establish the cause of death? And then secondly, you mentioned that the racial disparities after controlling other factors. What insights do you have that explains the differences in incidence by race?
We really don't know why we see the racial disparities we see. We do know that there are higher rates of other risk factors, so higher rates of preterm birth among certain populations, higher rates of non-supine sleep and bed sharing in certain racial and ethnic groups that we believe help explain some of the racial and ethnic disparities, but there's a portion of the disparity that is yet unexplained. Did that answer your entire question? I felt like there was a two-part there.
Weighting of different risk factors that you described.
That I don't know.
We're currently, and I'm a practitioner when it comes to the death investigation and performing cause and manner of death, and so it's less a weighted. What I can tell you is what I see often, but is not all inclusive. So I see the babies that come to me in an unsafe sleep environment that have succumbed in that environment are premature babies. Most of them were premature. They were not taking the term, and they're dying by 6 months in a unsafe sleep bed sharing environment. That is not 100% of these babies. Some babies are full term and still succumb in sleep environments, and so that unexplained, that's part of this process, is where the work needs to be done and where the work is being done.
I just want to add one more thing about the behavior. So what I can speak to is behavior. And I can tell you in one of our studies, we would often find that race was associated with, for example, non-back sleeping. But once you put in some of these factors that attitudes, social norms, and those sorts of things, race fell out of the model, meaning that it's not about race necessarily, it's about beliefs and attitudes and social norms, which is very reassuring when it comes to the behavior, because you can have an opportunity to change those things.
And I wanted to add that conducting case control studies where we can better quantify the risk associated with the various factors related to sleep-related infant death is an area of emphasis for us here at CDC. It's something we're working on currently. Online audience.
This is from Monica. Can you please comment on how babies sleeping with pacifiers helps decrease the risk of death? How do pacifiers help?
So the answer is we don't know. Sorry, Monica. But what I can say is that it's actually, the odds ratios are quite high. So it seemed to be very important. It's a marker of something, but we don't know what it's a marker of. The other thing that I would say related to that is it's also a hard one to follow, in the sense that people don't know exactly how to do it. Do I put the pacifier in the mouth, and what if it pops out? And so just in general, placing the baby to sleep with a pacifier and not worrying about whether or not it pops out. during the middle of the night. And then the other piece is balancing it with breastfeeding. And so that's why the American Academy of Pediatrics says offer the pacifier after breastfeeding has been fully established.
Okay, I think there's a question over on this side that we need to get to.
I was wondering if twins are at higher risk and whether putting twins on the same bed, whether that's considered unsafe sleep, or do you have to have two people of very different masses?
Twins, like all infants, should be placed on separate sleep surface to sleep most safely. I'm not sure that we've quantified risks separately for twins, but if they are being bedded together, if they're sleeping together, yes, they're at an increased risk if they are sleeping together. Do we need to go back to the online audience? We have several more we have a microphone person back here who's waiting patiently. Okay, let's go to the microphone. She's waiting.
Okay, cool. So I just wanted to echo Hamid's comments to say thank you to Dr. Hankey, because I think it's a great reminder that we can't always expect the science to speak for itself, and having those personal stories really, I think, increases the potency of the messages. I had a question for Dr. Coulson. You mentioned the obvious concern that women would report different behaviors once they know what you want them to say. And I'm curious how you're controlling that and whether you're confident enough in your study results to go ahead with scale up of some of the interventions that look so effective.
That's a great question, because we are often, when putting in our grants, asked, but isn't that self-report? And there are issues with self-report. And so we have tried various things to try to get more at what was really happening. It's just very difficult. You can't just burst into someone's home, obviously, to see what's going on. The one thing that is very, very reassuring is that all of the studies we've done over the last 20 years are quite consistent with the data. So we asked different people the same questions or slightly different questions, and we're getting the same information coming at us in different ways. So I would say that's one of the ways in which it's quite reassuring that we are getting at that. And then also with our randomized trial, we obviously have controls, and you could really see a change in behavior with the educational intervention. Now, is that because people know that that's what we're wanting them to say because they're getting these videos? Of course, it's a possibility, but the difference in response was so remarkable that we really feel that we've made a difference.
One of the things I wanted to say, I just wanted to, those on Facebook can't see that there's a considerable amount of men in this audience. And so I think it's important for men to have a good understanding of this. This is often something that is delegated to women that are actually childbearing. And so if you're a partner that's not childbearing, or you're the husband, it's important to support particularly the safe sleep environment. My wife fell asleep with breastfeeding all three of my children, and my job was to move them off the breast and move them into a safe sleep environment when they both fell asleep. So there's a way for partners, if you're the non-breastfeeding partner or you're the husband, to be involved in this type of care and this type of family development.
And I'm so glad that you said that. And it's a really important aspect of what we do, because we know that social networks, people around you, are so important in helping and also in influencing things that you do. So although we're often asking mothers about infant care practices, their family, their significant others, people who are important to them, play a very important role.
Okay, we'll take one more online question.
Yes, this is from Claire, directed to Dr. Coulson. Is there a resource for those laminated card templates you mentioned? The laminated card templates that you mentioned.
About getting access to them? So we are working on that. And we would like people, because now they've been tested in a randomized trial, we really think they're great. And we had a lot of help from staff in the hospitals in designing them, even testing them in pockets to make sure they fit. We had to go through all of our institution lawyers to make sure that we were allowed to release it. It's looking very favorable. We're down to one institution, which I will not name here because I'll get in very big trouble. And we will be hopefully be getting those out soon.
That's all we have time for today. Please thank the speakers for an outstanding session. Join us next month.